Good evening, everyone. How are you all? All right. So let's start our tonight's session. We are going to finish GIT today, hopefully. So in our last session, we finished abdominal pain and dyspepsia. So today we are going to start with dysphagia, which is difficulty swallowing. Okay. And also for all of you, as we said on multiple occasions, that when you join our session, you have to make sure that you write your name so that we know who you are. Okay, so if any of your name is not their actual name, it's showing Android or maybe iPhone, Samsung, we can't allow you to be on this session. So it's for safety for everyone. We need to know who is here, who is taking our classes and everything. So if you can please write your name when you are joining here, that will be really good. Otherwise, we will need to like remove you from this class, which is not ideal for you because you will not be able to rejoin the session. So few of your, like one of your name is coming as Windows 10. So if you can change your name, I will just send you a personal message so that you know who you are. And let's see, there is another one. Okay. Let's start our session with dysphagia. So what are the causes of dysphagia? So dysphagia can be due to a lot of reasons. It could be functional sometimes. That means there is nothing wrong, but patient feels something is there inside her throat. So that's functional. There is neurological cause, which is due to a stroke, myasthenia gravis, or motor neuron disease. Then there could be mechanical causes, and mechanical causes are, it could be like something is in the esophagus causing the dysphagia, like a foreign body. It could be a stricture or a tumor or a cancer, or it could be external compression, like someone who has got a large goiter, it can compress their esophagus, causing dysphagia. So these are the main causes of dysphagia. Now, as a whole, we divide the dysphagia into oropharyngeal causes and esophageal causes. So that's also important to understand that oropharyngeal causes, the patient will complain that they have difficulty initiating swallowing. Okay, so that means they have trouble to initiate the swallowing, which mainly happens in neurological causes like stroke patient, myasthenia gravis patient, or MND patient. They have difficulty to initiate their swallowing, and they feel that their food gets stuck at the suprasternal notch. Whereas esophageal causes, patients say that they don't have any difficulty initiating swallowing, but food gets stuck in the middle or lower part of their throat. They can also have pain on swallowing the solid food, especially meat, and eventually they can also have swallowing difficulty to liquids. So esophageal causes are mainly those are like the mechanical causes that you have seen here. A pharyngeal pouch usually causes regurgitation of undigested food, and gargling may be audible over the side of the neck. So that's one of the other causes of dysphagia. We will discuss that. Neurological disorder typically result in difficulty swallowing or coughing or choking due to food spillover. So basically neurological disorder patients, because of a stroke or something like that, they can't swallow properly because their swallowing reflex, gag reflex, those are all gone. So they have difficulty with initiating swallowing. Dysphagia for only solid indicates a structural lesion. So we are always worried about someone having dysphagia to solid because it could be a cancer. Okay. Dysphagia to both solid and liquid, most of the time it is due to esophageal motility disorder such as achalasia cardia. So what are the red flag pointers for dysphagia? So these are the symptoms or signs which will make you worry that there could be a possibility of a esophageal cancer. So age above 50, recent onset of dysphagia, unexplained weight loss, painful swallowing, which is also called odynophagia, progressively worsening of dysphagia, dysphagia to only solid, hiccup, hoarseness of voice, and any neurological sign and symptom. Okay, so these are the red flag point, and in those situations you would need to consider likelihood of a cancer, especially if it is a above 50-year-old sudden onset of dysphagia or gradually worsening dysphagia, especially to the solid. We will be very, very concerned. Okay, so what will be our investigation of choice? To investigate this dysphagia patient, first thing you need to know that is it a esophageal dysphagia or is it a oropharyngeal dysphagia? Okay, so if you suspect that this patient might have got a oropharyngeal dysphagia, which means like a neurological problem, then we do a video barium swallow. So we do a barium swallow and we find out like where exactly is the problem. Is this patient having difficulty to initiate the swallowing or not? So video barium swallow is the investigation of choice for a suspected pharyngeal dysphagia. Whereas if you suspect esophageal dysphagia, then endoscopy is the first line investigation. Okay. If endoscopy and barium study both are negative, still patient has got dysphagia, then we do this esophageal motility study, which will rule out achalasia. So that's the step-by-step management. So first you find out if it is a oropharyngeal or esophageal dysphagia. Just by the symptom of the patient, you can decide what type of dysphagia it is. Then you do that. And if those tests are negative, then you consider achalasia as your diagnosis. So you do the esophageal motility test. So let's discuss some of the common causes of esophageal, some of the common causes of dysphagia. So one of them is called benign peptic stricture. So what happens in benign peptic stricture, these patients usually give you a long-term history of chronic reflux. So long-standing reflux, what it causes that because of reflux, there is acidic backflow or regurgitation, and it causes inflammation of the lower part of the esophagus. Due to inflammation, fibrosis, adhesions, the lower end of the esophagus starts to get stricture or narrowed. Okay. Now, that is what we call as benign peptic stricture. So, following years of reflux, when a patient develops this kind of narrowing of the lower end of the esophagus, that's benign peptic stricture. So, what happens is that when patient had reflux, they used to get like lots of reflux, heartburn, burping, but suddenly their reflux and burping is gone, but now they started to get dysphagia to solid. Why it happened? Because now that the lower end is narrow, it is difficult for the reflux to happen, right? And because it's narrow, it's now difficult to get the food into the stomach. So they get dysphagia, but their reflux get better. So that's a classic finding that years of reflux, suddenly reflux has got better, but now patient developed dysphagia to solid. Okay, then you can diagnose this as benign peptic stricture. How to confirm the diagnosis? By endoscopy. If you do endoscopy, you will be able to see this narrowing of the lower end of the esophagus. So what will be the treatment? You need to treat the reflux. So if patient has got reflux, that has to be treated. But most of the time you can dilate the stricture. So there are pneumatic dilation. So lots of way to dilate the stricture are there. So you need to dilate the stricture so that food can go easily. Okay. So that's the treatment of choice for benign peptic stricture. How about esophageal cancer? To think of esophageal cancer, those red flags are very important. So let's say above 50-year-old coming to you with dysphagia towards the solid and patient progressively getting worse. And initially it starts with solid, and when it gets worse, then even liquid dysphagia will start. Patient can also develop worseness of voice and cough. They can get discomfort like a throat pain. But very important, because patient can't eat that much because of the dysphagia, they will lose weight. So weight loss is a very important finding to consider esophageal cancer. So sometimes question asks that what is the most common cause of esophageal cancer? Previously, smoking was the main cause. Nowadays, it has been changed. Nowadays, we say Barrett's esophagus is the most common cause of esophageal cancer. And after Barrett's, smoking. So if you suspect esophageal cancer, what will be your investigation of choice? Endoscopy, not barium swallow. Endoscopy is the main diagnosis. Previously, according to JM, it is still like squamous cell cancer is the commonest, but nowadays adenocarcinoma is the commonest esophageal cancer. So that has been changed. Okay. Next, achalasia cardia. Achalasia cardia is a motility disorder. So that means definitely you understand that for the esophagus to send the food into the stomach, it needs this peristaltic movement. So if that peristaltic movement is not there, it is what we will call as esophageal motility disorder. And the most important motility disorder is achalasia cardia. So in this case, what happens is that esophagus becomes widely dilated. So it becomes dilated and it loses the elasticity that would cause this, like that peristaltic movement. So no longer peristalsis is there. Not only that, the esophagus becomes dilated and it ends like a smoothly tapered lower end. So it becomes like this. Let me show you. So see, the esophagus is like hugely dilated, and now it is ending like a barred beak appearance. So when it ends like this smooth end like a bird's beak, then we call it achalasia cardia. Now, this kind of motility disorder doesn't come to you straight away. It takes some time. So it is a gradual onset of dysphagia to both solids and liquids. So in these patients, weight loss is not like esophageal cancer patient. So even achalasia cardia most of the time doesn't cause any weight loss. So it's a disorder of esophageal motility disorder in which the esophagus becomes widely dilated and then it ends as a tapering smooth end, okay, like a bird's beak appearance. Now, if you think that this could be achalasia cardia, what will be your investigation of choice? So ideally, we can start with barium swallow. So endoscopy will not be able to say anything in here. So your initial investigation can be barium swallow. If barium swallow is not giving you much information, or if the question asks you the most definitive test, that's esophageal manometry. Okay, so confirmatory test is manometry, and initial or next investigation of choice is barium swallow. How to treat achalasia? In elderly patient, or patient who has got multiple surgical comorbidities or who doesn't want surgery, for them, conservative treatment is ideal, like nifedipine or sometimes botulinum injection into the sphincter. Sometimes you can also try pneumatic dilation of the esophageal sphincter. If pneumatic dilation not helps, then you can go for surgical myotomy, which means you just remove this part of the esophageal muscle, which is narrowed or fibrosed. Okay, so the treatment, ideally we say that in case of elderly patient, either nifedipine or sometimes even pneumatic dilation can be done. But surgery is not usually the first line option for elderly patient. But if someone wants to totally cure it, then the only way to cure this is surgery. Okay. So conservative for elderly patient, which is nifedipine or pneumatic dilation, and then for other group of patients, surgery is the main choice of treatment. So you can see in here, if you do a barium swallow, it shows this bird's beak appearance like this. So this is from Kaplan step to Seke. Kaplan says that initial treatment is pneumatic dilation and then surgery. Okay, but according to James, which is what we are going to follow, James says that you can even try nifedipine in an elderly patient first. And if that doesn't work, then you go for pneumatic dilation in elderly patient. And for patients who are not elderly and also patients who don't have any surgical comorbidities, you can even try the surgical method. Okay? So initial diagnosis is barium swallow for achalasia cardia, and confirmatory is esophageal manometry. Nifedipine acts as a dilator, so it can dilate the esophageal sphincter. Okay, so that's achalasia. This is called globus sensation. Sometimes a patient can come to you saying that, doctor, I feel something is inside my throat. So it is a subjective sensation of a lump in the throat, usually associated with some psychological problem. But again, you can't be sure until you do everything. So you'll find out that you will do endoscopy, barium, you might even do a manometry, everything comes normal. Then you can diagnose this as a global hystericus or globus sensation. Odynophagia is painful swallowing. There are lots of causes are there for odynophagia. You can go through it. Okay, very important topic, eosinophilic esophagitis. There is a RACGP guideline for eosinophilic esophagitis, which I want you guys to go through. Okay, it's a very important topic. Lots of confusion is there because how RACGP has written it, that's why it is a bit confusing, but I'll try my best to make it as simple as possible. So eosinophilic esophagitis, it is also one of the cause of dysphagia, and sometimes it can feel like food bolus getting obstructed into the throat. It can happen in both children and adults. So it should be considered in those who regularly experience food getting stuck in their throat. But very important is that, like this eosinophilic, the name suggests, so eosinophilic esophagitis is commonly associated with some other allergic disorder, such as hay fever, eczema, allergies. And in these patients, IgE will be elevated. So what you do in a patient who has, let's say, known allergic disorder, and now coming to you with a sensation that food getting stuck in the throat. In those patients, first of all, you will send the patient for an endoscopy or gastroscopy. And in the endoscopy, you can get eosinophilic infiltration in the esophageal mucosa. And that can confirm the diagnosis. There are some food which can make it worse. So that's why there is a 6-food elimination diet that sometimes can help to reduce the symptom in 90% cases. But if it is an acute attack, the treatment include IM Buscopan and a solid topical steroid like fluticasone. Okay. Now, before we move forward, I want to go through the RSCGP guideline a bit. Okay, so this is the diagnostic criteria for eosinophilic esophagitis. So first of all, symptom related to esophageal dysfunction, which means feeling something is inside the throat, more than 15 eosinophil on esophageal biopsy, persistence of eosinophilia after a PPI trial. So you give a trial with a PPI and then you do a endoscopy and still eosinophilia is there, then it is likely to be eosinophilic esophagitis. Okay. So initial diagnostic test for patient with suspected this condition should be an upper GIT endoscopy with biopsy. Diagnosis requires persistent esophageal eosinophilia following a course of PPI treatment. PPI treatment for a period of 8 weeks preceding the diagnosis of eosinophilic esophagitis is important to distinguish between true esophagitis or GORD. Okay, so option is that if there is no other red flag and patient can wait for 8 weeks before going for a endoscopy, then you will try a PPI for 8 weeks and then you do a endoscopy. And even after treatment with a PPI for 8 weeks, there is eosinophilia on the esophageal biopsy that will give you the diagnosis. So we say normally you start with a PPI for 8 weeks and then you send the patient for endoscopy. And there are lots of differentiating factors between eosinophilic esophagitis and reflux esophagitis, which you can read. So management. So dietary modification is an effective first-line treatment, which is that 6-food elimination diet. Pharmacological treatment is only needed in patients who do not respond to the dietary measures. Topical steroid, fluticasone and budesonide are the initial treatment of choice. And these are given by the patient swallowing the steroid solution. Okay? So it is called topical steroid aerosol. So patient will swallow this steroid. And that's mainly the treatment. Okay? So now where it actually gets confusing in the exam is that they give you a scenario where it could be eosinophilic esophagitis, and then they ask you that what will be your next appropriate management. So my idea is that if in the exam they already say, like they already give you the diagnosis that endoscopy shows patient having eosinophilic infiltration In that situation, it means we already diagnosed it. So if a patient has all the symptoms of eosinophilic esophagitis and the endoscopy has confirmed the diagnosis, like this, endoscopy confirms eosinophil on esophageal mucosa. So if it confirms like that, then we don't need to even think of giving the proton pump inhibitor. Then we can choose from either the dietary elimination, or we can choose any of these topical steroid or Buscopan. If the question says that no, patient with known allergic problem, having a feeling of swallowing difficulty, food getting stuck in the throat, what will be your next most appropriate management? In that situation, next most appropriate should be a PPI for 8 weeks, followed by an endoscopy. Okay, so our condition is that if question already says that this is eosinophilic esophagitis, if it confirms the diagnosis, there is no point of giving PPI. But if it doesn't confirm, then we give PPI as our first thing. Does it make sense for everyone? So IgE is not the investigation for this case. Okay, Dr. Shabab. So endoscopy is the ideal choice, or you can say it is the initial investigation of choice. And Dr. Nahid, you got your answer. So if a stem says that it is confirmed, then there is no point of giving PPI, because confirmed case, the treatment will be a steroid. Okay, so if question confirms that this is eosinophilic esophagitis, then treatment is a steroid. If it doesn't confirm, then it is PPI. Simple. And you can also read some of these practice points, nothing much. Remember one thing, is scleroderma, which is a connective tissue disorder, also causes dysphagia. We will discuss that in our connective tissue disease class. There is another condition called diffuse esophageal spasm. In diffuse esophageal spasm, what happens is that the esophagus becomes spastic. It is kind of a idiopathic abnormality of the nervous system of the esophagus. So sometimes the esophagus comes into spasm. Remember that coronary spasm, which is like fringe metal angina? In the same way like that, sometimes esophagus can get into spasm, which can cause dysphagia. And sometimes this patient also gets intermittent chest pain. Excuse me. So intermittent chest pain with dysphagia is suggestive of diffuse esophageal spasm. How to confirm it? The confirmation is by barium solo, and you will get a corkscrew pattern. See, this is called the corkscrew pattern, which you get this kind of esophageal spasm patient. How to treat this? So you can give them calcium channel blocker like nifedipine or nitrate. So this is the flow chart of all the dysphagia that we have discussed so far. So let's say we have got a patient whose food gets stuck in the chest after swallowing. So that means it is esophageal dysphagia, because patient can initiate swallowing, but food gets stuck in the middle. Then we look at if it is only solid or both solid and liquid. If it is both solid and liquid, then likely cause is achalasia cardia. But with that, if a patient has got intermittent chest pain, then you can think of diffuse esophageal spasm. Okay? How about solid? Solid means most likely there is a mechanical obstruction. Is it intermittent? or progressive. If it is intermittent, then it is likely to be benign esophageal stricture. If it is progressively worse, then we think of cancer. Okay, so ideally, if it is only dysphagia to the solid, then either you think cancer or you think of benign peptic stricture. It is very easy to differentiate between these two because benign peptic stricture will take years of reflux, whereas cancer will take maybe just few weeks or months. Okay. Rings and webs, not very important. Janker's diverticulum is important. I know, Dr. Nahil. So that is the problem, right? Like this box makes all the confusion that you guys are having. But the box says the question is important. If your question says that patient is having a diagnosed case of eosinophilic esophagitis, that means they have done this part already. You can only diagnose eosinophilic esophagitis after a trial of PPI. So if your question says they have already diagnosed the patient, that means diagnosis is done. All you need to do is to treat the patient. Okay, so you have to understand what the question is saying. Janker diverticulum. So Janker diverticulum is also called pharyngeal pouch. So pharyngeal pouch, if you look over here, you can see what we are talking about. It's kind of a outpocketing of the posterior pharyngeal constrictor muscle. Or you can just say that it's kind of a abnormal outpocketing of the esophagus. So a 25-year-old medical student comes to seek your help because he thinks he has bad breath. This past weekend, a most disturbing event occurred while he was watching a football game. He coughed up the chicken teriyaki he ate 2 days earlier. So what happens that food can go into this pouch, then definitely it will not be digested and it will cause bad breath, and sometimes patient can regurgitate the whole food back. Okay. So it is common in elderly patient, but it can happen in any age group. So this is generally a very slowly developing problem, occurs in an older patient. Patients usually have bad breath, difficulty initiating swallowing because it is a proximal lesion. Patient also complaining of having to repetitively clear their throats and waking up with undigested, regurgitated food on their pillow. This is particularly unpleasant because the food was usually eaten several days ago. Okay, so how to diagnose this condition? The only way is barium swallow. Now, this is one of the cases where endoscopy or even placement of a NG tube is contraindicated because you can perforate the pharynx. Okay, so if there is a classic picture like patient having bad breath, regurgitating the whole food back, then don't go for endoscopy, send the patient for a barium swallow. And treatment is surgical repair. Okay, next, Mallory-Weiss syndrome. Mallory-Weiss syndrome is not a part of dysphagia. Our dysphagia chapter is over. So that's all that actually you need. You don't need to go through anything else except what we have done. I have taken things from JAM, RACGP, and also from Kaplan Streptococci. That's enough for your preparation. So don't go for anything else. Now coming to hematemesis and melena chapter, especially hematemesis. So patient with hematemesis means vomiting out the blood. We are always concerned about these patients, especially if someone having persistent continuous bleeding. One of the cause of hematemesis is Mallory-Weiss syndrome. So what is this Mallory-Weiss syndrome? It is a non-transmural tear of the lower esophagus that is related to repeated episodes of retching and vomiting. It is an esophageal disorder. It does not present with dysphagia or odynophagia, but it presents with a painless upper GIT bleeding. So many times what happens, patient had a binge drinking, and after binge drink, patient started to have dry retching and vomiting heavily. That can sometimes cause a bit of tear in the lower end of the esophagus. And that time, patient will have a little bit of bleeding with the vomiting. That is what we call as Mallory-Weiss syndrome. So painless bleeding with vomiting. That is Mallory-Weiss syndrome. Always remember, first patient will vomit, then they will have a tear in their lower esophagus, and then they will have a bleeding. And it is painless. So if you suspect something like this, how you diagnose this? You can send the patient for an endoscopy. Most of the time, Mallory-Weiss tear does not require any treatment because it resolves on its own. But if it doesn't and patient have continuous bleeding, then you might need to inject some adrenaline into the bleeding point or even sometimes cauterize. Depends. So there is another condition which is called Boerhaave syndrome. Boerhaave syndrome is another cause of this kind of hematemesis. Let's have a look. So we'll go into med bullets for it. So Mallory-Weiss was non-transmural esophageal tear. That means it does not cause complete rupture. What if a patient has got a complete rupture of the esophagus after an episode of vomiting? So both is related to vomiting, but Mallory-Weiss is just a small tear and it does not cause complete rupture. Boerhaave syndrome is complete rupture of the esophagus, and it usually happens due to increase in the intrathoracic pressure or intraesophageal pressure. What causes increase of intraesophageal pressure? If someone having a vigorous vomiting or vigorous dry retching. So patient will have this kind of thing like excessive vomiting and retching. Following that, patient will have a severe retroesternal chest pain, profuse vomiting, and painful swallowing. So this one is painful. Okay. So initially they start with dry retching or vomiting, and sometimes they can have a bit of bleeding also, but it will be extremely painful in the lower sternum. So excruciating retroesternal chest pain, profuse vomiting, and odynophagia. You can also sometimes feel crepitation on the chest wall because of subcutaneous emphysema. Now, if you suspect Boerhaave syndrome or complete rupture of the esophagus, what is your investigation of choice? We normally start with a water-soluble contrast, which is gastrografin meal. Okay, so or gastrografin solo, not meal, sorry. So you do a gastrografin solo, which is a water-soluble contrast, and that is usually your initial investigation. Can we use if we do a CT scan, can we do a contrast CT? We can't use the contrast dye because it is a ruptured esophagus. And if you use contrast, especially with the barium, okay, so especially if normally with the barium, normally with the esophagogram, the barium dye, it can go into the chest because it is already a perforated esophagus, and it can cause life-threatening complication like mediastinitis. So we don't use barium in here, rather we use gastrografin solo. Okay, because it is water soluble and it does not cause any problem. Now let's say you have done the contrast esophagogram like a gastrografin solo, but you can't be sure that if this is a rupture or not. In that patient, you can do a CT scan. Okay, so contrast esophagogram or gastrografin solo is the main investigation, and if that doesn't work, then you can do a CT. If they ask what is the confirmatory investigation, CT is much better than esophagogram. Okay, but initially you should start with the gastrografin solo, and definitely the treatment is repair of the rupture. Now, there is a chapter in John Murtagh about hematemesis and melena. I want you guys to go through that when you can, but the important parts are discussed at the moment, which is Mallory-Weiss and also the Boerhaave syndrome. Now, let's go into that chapter just for a minute so that you know what I'm talking about. That's chapter 44. It's a very small chapter. Right? Go through this key fact and checkpoint. Remember, the most common cause of upper GIT bleeding or hematemesis is chronic peptic ulcer, like a bleeding peptic ulcer. And in here, you can see what are the causes of upper GIT bleeding. So mainly peptic ulcer, gastric ulcer, esophagitis, then Mallory-Weiss. Then you have got some of these anti-inflammatories. Esophageal varices, like a variceal bleeding, is also common, especially in cirrhosis patient. We discussed Mallory-Weiss. Esophageal varices. So patient who has chronic liver disease, they develop portal hypertension. All of you know that because I guess you know about cirrhosis a lot. It's very common. So patient with chronic liver disease, they develop portal hypertension. And one of the complications of portal hypertension is gastroesophageal varices. And these varices, they are very immature, tiny little blood vessels. They can easily burst and can cause hematemesis. Right? So if it's a known case of liver cirrhosis and patient coming to you with the upper GIT bleeding, you should consider first that it is likely to be a variceal bleeding. That's why in a known patient who has portal hypertension, as a preventative, we put them on beta blocker like propranolol to make sure that this varices does not bleed. So primary prevention is propranolol. But remember, once the patient starts bleeding, propranolol can't stop the bleeding. So what can stop the bleeding when patient comes to you with a variceal bleeding? So management include injection of sclerotherapy, then intravenous octreotide or terlipressin if it fails. So according to JM, they say that if it is a variceal bleeding, you start or your main treatment will be injection of sclerotherapy followed by intravenous octreotide or terlipressin. And then there is, like sometimes there are lots of tamponade is possible. Even sometimes there is TIPS, which is transjugular intrahepatic portosystemic stent. These are all possible options, doesn't come in exam. The initial thing comes in exam. So injection of sclerotherapy followed by octreotide or terlipressin. Now we'll come to this just in a bit. So go through these initial things like investigations and all. Management. If a patient coming to you with a upper GIT bleeding, the patient can become unstable quite quite easily. So stabilizing the patient is your first priority. So urgent resuscitation is required when there is a large bleeding and patient is in shock. So for this patient, you need to put them with IV fluid, and also sometimes you can even give them plasma expander like Hemakel, and as soon as the blood is available, blood transfusion. So initial is definitely stabilize the patient with IV fluid and then blood. Next, proton pump inhibitor should be commenced in most cases, especially if you suspect peptic ulceration. And it's not oral PPI. Most of the time, we start them with the 80 milligram of IV PPI. Okay, so that's the second option. In some cases, bleeding can stop by its own, even with these initial measures. But if bleeding continues, then you have to send the patient to an endoscopy, so urgent endoscopy. Either you can cauterize the bleeding point, you can use a heater probe, you can inject them with adrenaline, or you can apply a clip. All of these are possible way of stopping the bleeding. Okay, so this is actually the step-by-step management, but I will show you the guideline that we follow in Australia. Any kind of emergency management, if you want to look into the guideline, you can always write this aci.health.nsw. So any emergency cases, if you want to read precisely, then this is a very good guideline. So emergency management of upper GIT hemorrhage. Definitely you will find out what kind of risk this patient has got, like is this patient having a peptic ulcer and like chronic use of NSAID. So there will be something that you will be able to find. Let's say patient having a major bleeding. Major bleeding means persistent bleeding and patient is going into shock. So that means you stabilize the patient with IV fluid. Initial resuscitation is same like how we have talked about. And then you start the patient with IV pantoprazole. Then you look at that, is it a non-variceal or variceal bleeding? Variceal bleeding, you will already know because patient will be a known CLD patient. If it is a variceal bleeding, then you can start them with octreotide, antibiotic, endoscopy for banding or injection. Now, this is where there is a contradictory thing from JM and the Australian other guideline. In a practical point of view, we would do this management in a hospital setting rather than what JM said. So if we suspect variceal bleeding, we will do the same thing. So IV fluid, wait for the blood, start them with a 80 milligram pantoprazole, and then if we suspect it is a variceal bleeding, we start them with octreotide IV, antibiotic coverage, followed by endoscopy. Either we try to band the area from where the patient is bleeding, or we go for a sclerotherapy. Okay, that's variceal bleeding. If it is non-variceal bleeding, then it is likely that it could be a peptic ulcer bleeding. So you have already started PPI, then you need to send the patient for endoscopy. With the endoscopy, you can try any of those. So endoscopy, you can try injection, electrocauterization, okay, tamponade, anything. But you have to stop the bleeding with anything that you have. Normally, we say that you go for heater probe or electrocauterization plus or minus injection of adrenaline. That's the treatment. This is another guideline for hematemesis. Definitely read it because this is an important topic for exam. So octreotide or terlipressin. So octreotide is your first option. If there is not in there, then you do terlipressin. CT angiography only needed in upper GIT bleeding, Dr. Shia, if endoscopy is not available. Like in here, they have written, if endoscopy unavailable or contraindicated, then you can consider a angiogram in this patient. But again, it is an interventional angiogram. It's not a CT angiogram. Okay. So for upper GIT bleeding, CT angiogram cannot do much. But for lower GIT bleeding, yes, there are a few things that can help. Like we can do angiogram and other stuffs, but it's not upper GIT. In lower GIT, capsule endoscopy, CT angiogram has some role, but not upper. For upper GIT bleeding, let's say that if there is nothing coming out as a hematemesis, but patient having melena. In a melena patient, sometimes we can do a capsule endoscopy. Capsule endoscopy is our last option. It is on after we have done everything. We have done endoscopy, colonoscopy, we have done a CT angiogram, everything has been done. Still we can't find out the cause of bleeding. Then last option will be capsule endoscopy. Yes, so in variceal bleeding, first step will be octreotide before endoscopy. That's right. How to know if it is variceal or non-variceal? In a variceal bleeding, patient will be a known patient of CLD. If it is not a known patient, you can't be sure. Okay, let's open up the chapter 31 quickly. So before we take the break, we will finish the constipation chapter. It's not like a huge chapter, but again, there is only one important thing in here, which is a bowel cancer. So we'll discuss that. So all of you know what is constipation. It is the difficulty to pass stool. And we say constipation if there is less than, like, if there is less than 3 bowel opening in a week, that's constipation. There are lots of causes of constipation, which you can go through from here. And in here, there are some causes of constipation. There are functional constipation. Sometimes even colon cancer can come as constipation. So any recent change in bowel habit, especially in middle-aged or elderly patient, we are always concerned. So what is the commonest cause of constipation? The commonest cause is functional or idiopathic constipation, which means there is no known cause. It just happens. And most of the time, the lack of dietary fiber, lack of fruits, veggies, that's the main cause of having constipation in Western countries. So what are the alarming symptoms in a patient with constipation? Recent onset of constipation in a patient above 40, parectal bleeding, even if it is fresh blood, family history of cancer, positive FOBT. Okay, so FOBT is fecal occult blood test. So what is fecal occult blood test? It is a kind of a stool test. So you send the stool to the lab, and lab looks into the stool for any kind of hemoglobin or red blood cell. So only time we do the FOBT if if we are looking for a occult bleeding, but patient cannot see any blood on the stool. Okay, so sometimes in the microscope you can be able to see some red blood cell. Excuse me. So these are all the alarming symptoms for constipation. Moving on, so you can read this part, endoscopy, colonoscopy, those things, you can do it in your own time. Idiopathic constipation. So idiopathic constipation, as we discussed, that this is the most common cause of constipation, and most of the time it is related to lack of diet, lack of water intake. So how we manage this kind of idiopathic constipation? So first of all, advice for some good dietary habit. And then as part of the management, you have all of these laxatives. So there are some hydrophilic, there are some stimulant, osmotic laxatives, there are some stool softening agents, and then there are some suppositories. Now let's say what is commonly used in Australia, step by step. So first line treatment for any constipation is just using some bulk forming agent. So the general bulking agents are psyllium or Ispagula husk. So that will be the first thing that patient can try. Let's say they tried this dietary fiber thing, did not work. The second line is a osmotic laxatives, which is commonly Macrogol, known as Movicol in Australia. Excuse me. Lactulose syrup or Docusena. So this second line therapy is very commonly used. So Macrogol or Movicol, Lactulose or Docuset plus Sena. Let's say that did not work. The third line is magnesium sulfate, glycerin suppository, and is still not working, then there are enemas, phosphate or microlax enema. Okay, so that is the step-by-step management for constipation. Read it few more times, it will come into your head. Okay, there is constipation in children, which I would like you guys to go through. I think we discussed that maybe a bit in our pediatric class, but definitely read that as well. Fecal impaction. Now, that is one of the important topic for exam. So, patients who are elderly, sometimes they can develop this fecal impaction. So, what happens in this case that long-term constipation, patient not opening the bowel for let's say 5-6 days, and then the hard stool will be there in the rectal area. On the top of the hard stool, there will be soft stool. And sometimes the softer stool, it will push the hard stool in a very like hard way, and sometimes patient can have a diarrhea. Okay, so we say that this is called spurious diarrhea. So let's say that this is the bowel or rectum, and in here there is hard stool, and over here all are soft stool. Sometimes soft stool can come from the side of the hard stool and then taking the whole thing out, causing a spurious diarrhea. So spurious diarrhea, the underlying cause might be fecal impaction or constipation. So elderly patient coming to you with spurious diarrhea, malaise, anorexia, nausea, abdominal discomfort, bloated sensation, sense of inadequate defecation, that is the time when you think of fecal impaction. If you palpate their tummy, you might be able to feel like a hard mass on their abdomen. It is very common in patient who takes opioid because opioid can cause constipation. So if you suspect that in an elderly patient there might be a fecal impaction, the first thing that you do is the parectal exam. you feel the rectal area for any hard stool. And then you can do a plain X-ray of the abdomen, which can confirm it. If it is confirmed, then you will give them first laxatives. So either you can try like a high dose of Macrogol or Movicol. If that doesn't work, then you go for enema. If enema is not working, then manual disinfection. That means with your finger, you will need to remove them. Okay, so that's the treatment for fecal impaction. Next, colorectal cancer. Now, this is a very, very important topic for your exam. It is one of the commonest malignancy in Australia. So, the commonest GIT malignancy is adenocarcinoma, second most common cause of death from cancer in Western society. Common in men over 50, mainly in the descending colon and rectum. So what are the risk factors for colon cancer? The risk factors are ulcerative colitis, familial adenomatous polyposis or HNPCC, which is hereditary non-polyposis colorectal cancer. So this is like very, very high risk patient. Colonic adenomata, age above 50, decreased dietary fiber. So you can see in here the lifetime risk of having a colon cancer. A patient who has one first degree relative diagnosed with colon cancer after 45 has a risk of colon cancer 1 in 17 patients. One first degree relative less than 45, 1 in 10. Now have a look on here. HNPCC, 1 in 2. And FAP, 1 in 1. So these are very high risk patients to develop a colon cancer. Okay. So remember this risk because sometimes they ask you. So how a colon cancer patient usually will come to you. So lots of presentation are there. So patient can come to you with a parectal bleeding, mucus discharge. They can have a recent change in their bowel habit, alternating constipation with spurious diarrhea. They can also have like unsatisfactory defecation, abdominal pain. Sometimes they can even present with an iron deficiency anemia. So if you look on this picture, you can see how like site of the cancer can cause different kind of symptom. Like we say that if it is on the right side, like a cecal cancer, patient most of the time comes with iron deficiency anemia. Whereas if it is a sigmoid colon cancer, they come to us with a parectal bleeding or altered bowel habit. Same if it is in the rectum, rectal bleeding is the common cause. Okay, so right-sided colon cancer, most common symptom is iron deficiency anemia. Whereas left-sided colon cancer, main symptom is altered bowel habit and sometimes parectal bleeding. So how we investigate a patient who we suspect that they can have a colon cancer? Always remember the confirmatory test or your most appropriate test if you suspect colon cancer is colonoscopy. Although in JM they have written CT and CT colonography as the investigation of choice, CT colonography is still not available in Australia in most of the hospitals. And we normally don't directly go for CT colonography anytime. So we start with colonoscopy. For some patient, if there is no parectal bleeding, and we want to know that if the patient is bleeding internally, then we can do FOBT. FOBT is a screening test. It's not a diagnostic test. Okay. So ideally, FOBT is not usually our investigation of choice. Our investigation of choice for a suspected colon cancer is always colonoscopy. If colonoscopy unsuccessful, or you could not pass the colonoscopy like quite deep into the colon, in that case, you can go for CT colonography. Sometimes what we do, we tried colonoscopy first time, it was unsuccessful. Sometimes we try twice. So we try again, see if we are able to do it. Still we can't go pass into the main part of the colon due to something. Then we go for CT colonography. Okay. So remember that, because it confuses a lot of people, because it is written in here CT colonography is the investigation of choice, but this is not the usual case. Remember serum CEA, carcinoembryonic antigen, it is not used for diagnosis but used for like a prognostic purpose. Colon cancer screening. Colon cancer screening is super important for exam. So every patient who is above 50, they're supposed to get a FOBT every 2 yearly. So FOBT every 2 yearly from 50 to 74, it's for every Australian, whether they have a risk or not. Everyone above 50 will have a FOBT test every 2 yearly. Okay, so that's why it is a screening test. But there are some group of patients who are moderate risk or high risk. For them, you might need to send them to colonoscopy. According to JAM, patients who are in moderate risk, JAM says to do the FOBT every 2 yearly from 40 to 49, and then colonoscopy every 5 yearly from 50 to 74. And for high risk patient, 2 yearly FOBT from 35 to 44, and colonoscopy every 5 yearly from 45 to 74. Now, that is usually the case. Most of the time, this is what we follow. So I want you guys to memorize these three things. One, so this one is for low risk patient who will get FOBT 2 yearly from 50 to 74. Moderate risk, now who are moderate risk, we are going to discuss. Moderate risk patient will have FOBT 2 yearly from the age of 40. Okay, so 40 to 49, they will do the FOBT. From 50, they will start colonoscopy every 5 years. High risk group, FOBT every 2 yearly from 35 up to 44, and then colonoscopy every 5 yearly from 45. It is very difficult to keep it in the memory, but you'll need to memorize it. Print it out, keep it in front of you so that you can memorize it every day, because it is very important for exam. Now, let's talk about who are the moderate risk and who are high risk. Okay. So for any kind of screening, so screening is a very important topic for your exam. For any kind of screening, we follow Red Book Australia. Okay, so there is a whole, like a very big book where all the screening that we do in Australia, it's written. Not all the screening comes in exam, but the important ones are especially we say that colon cancer, then breast cancer, prostate cancer. These three screening is must for your exam: colon, breast, and prostate. Apart from that, you should also read a little bit about ovarian cancer. You should also read a little bit about diabetes screening. Okay, So all of this screening you will be able to find out in Redbook Australia. And currently the 9th edition is the edition that we are following. Okay. And it's still in Australia, we are following this Redbook for any kind of screening. So let's see. No, the Redbook is not something we can upload in the portal, which you can easily find in the Google. Okay, all you need to write is Redbook Australia, and you will be able to get the PDF. Okay, now coming to this colorectal cancer. So there are 3 groups. One is category 1, then there is category 2, and then there is category 3. Category 1 is the low risk population. So low risk are patient who does not have any history of bowel cancer in their family. So no personal or family history of colon cancer after the age of 50. This low risk also include 1 first degree or 1 first degree, 1 second degree relative who was diagnosed with colon cancer after 55. So who is first degree and who is second degree? First degree means like your parents, your siblings, and your offsprings or children's. These are all first degree relative. Okay, so parents, siblings, and children's. Who are second degree? Maternal uncle, paternal uncle, aunt, okay, grandfather, grandmother. Those are all second degree relative. So we say that 1 first degree or 1 first degree, 1 second degree relative diagnosed with colon cancer after 55, they are also low risk. So for this group, what will you do? FOBT every 2 yearly from 50 to 74. We also say low dose aspirin sometimes can prevent colorectal cancer. So we advise them to take it at least 2.5 years at 50 until 70 years of age. So we give them low dose aspirin, which can prevent colorectal cancer as well. Coming to the moderate or category 2. So moderate risk are patients who has a first degree relative diagnosed with a colon cancer before 55. So that's the main one which comes in exam. The other option is 2 first degree relative diagnosed at any age. 1 first degree, at least 2 second degree diagnosed at any age. Okay, so these are category 2. For category 2, idea is they has to have a FOBT every 2 yearly from 40 to 49 and colonoscopy every 5 yearly from 50 to 74. Making sense for everyone, the category 2. So 1 first degree before 55 or 2 first degree at any age, 1 first degree, 2 second degree at any age. They're going to have FOBT from 40 to 49 and then from 50 colonoscopy every 5 yearly. Now, category 3 or high risk. High risk patient could be at least 3 first degree relative or second degree relative, one of them diagnosed before 55. So that means 3 first degree or second degree relative diagnosed with cancer and one of them diagnosed before the age of 55. And 3 first-degree relatives diagnosed at any age. They are also high risk. But most importantly, if there is a family history of hereditary non-polyposis colorectal cancer, which is HNPCC, which is also known as Lynch syndrome, that's a high risk. If someone in the family diagnosed as familial adenomatous polyposis, that's also category 3. Okay? For this group of patients, you have to do FOBT every 2 yearly from 35 to 44 and colonoscopy from 45. These patients, because they are high risk, you need to also refer them to familial cancer clinic for genetic risk assessment. And they also needed to be referred to a bowel cancer specialist. Okay? So we say that for this group of patients, this is what we normally follow, but every patient is different and they have a different kind of risk. So for this group of patients, they need to see a familial cancer clinic for a genetic risk assessment. Okay? And in here, they have also written what is Lynch syndrome, what is FAP and everything. Read this whole page, okay? That's important. So management of colon cancer. So guys, do you have any questions with the bowel cancer screening? Now it is very difficult. So don't think you will be able to memorize the whole chart just by my discussion. It is impossible. So if you have understood what is first degree, second degree, and what are the important things, that's all that you need to understand for today. Do we give low dose aspirin even if no family history? Yes. So it's usually given for everyone above 50. So management for colon cancer is surgical excision. And in here they have written the modified Duke's classification of colon cancer and also their 5-year survival rate. Sometimes question also diagnosed a patient with colon cancer and fortunately the cancer has been resected. How you're going to follow up the patient? The initial 1 year, you follow up the patient with carcinoembryonic antigen, CEA. And after 1 year, you start to do regular colonoscopy. Okay? So that's all about the colon cancer and also the constipation chapter. Now we are going to take a 10-minute break and after that we will start with chapter 34. Any question, guys? All right, so 10-minute break for everyone. If there is any question, write it in the chat box. We will discuss after the break is done. All right, everyone, let's start again. So, Dr. Chandima, do we need to know colon cancer staging and surgery options? No need. So, normally we do surgery if it is not metastasized, but if it is a colon cancer which is metastasized, that usually needs a chemotherapy. Okay. All right, let's start with chapter 34, diarrhea. It is also an important chapter. Lots of cases are there which comes in exam. So go through the initial checkpoint by yourself. And over here there are some common causes, like what are the causes of acute diarrhea and everything, which you can read. Okay, starting with pseudomembranous colitis or antibiotic associated diarrhea. So this can be potentially fatal, and it is a colitis caused by some of the antibiotic, commonly clindamycin, lincomycin, ampicillin, and some of the cephalosporins. So what it does is that after taking these antibiotic, patient can develop an overgrowth of a bacteria called Clostridium difficile. And this can produce a toxin which causes an inflammatory lesion and sometimes even a pseudomembrane. Because of that membrane on the top of the intestine lining, patient develops a very severe diarrhea. So profuse watery diarrhea with abdominal cramping, and usually starts within 2 days of taking the antibiotic, and even it can persist 2 weeks after ceasing the antibiotic. Always remember that sometimes this Clostridium difficile, that means the pseudomembranous colitis, it can even start 4 to 6 weeks after having an antibiotic. So even after a month of taking an antibiotic, patient can come to you with this kind of pseudomembranous colitis causing profuse watery diarrhea. Although it is mainly watery diarrhea, patient can also get bloody diarrhea. Okay, so just because question says there is blood in the diarrhea, don't just rule out pseudomembranous colitis. So how to diagnose? So according to JEM, it is the sigmoidoscopy is the main diagnosis, but normally what we do in a practical scenario is we send the stool for Clostridium difficile toxin PCR. And that is usually the diagnosis. That's all that we really need to do. So we send the stool for C. diff toxin. Now, in the exam, if they ask the initial investigation, that's your C. diff. If they ask confirmatory investigation, then you can think of the sigmoidoscopy. So you do a sigmoidoscopy and you take a culture from the colon, and that can also grow the C. diff. So why we'll do like a sigmoidoscopy and then take a tissue culture where we can just get the stool and do the PCR. So that's easier. So that's why stool for C. diff PCR is the normal investigation that we will always do to start with. Okay, but if they ask confirmatory, then go for sigmoidoscopy tissue culture. So if patient is still on antibiotic, then you have to stop the antibiotic. That's the first thing that you would do. If it is mild to moderate, then metronidazole for 10 days. If it is severe, then vancomycin for 10 days is the treatment of choice. Okay. So these initial things is for you to go through. I'm not going to read all of these things. You can read it. Malabsorption. So one of the cause of chronic diarrhea is malabsorption. Malabsorption means that from the bowel or from the intestine, the food or nutrients are not getting digested. There are lots of causes of malabsorption. One of the most important cause of malabsorption is celiac disease, okay, which is a gluten-sensitive enteropathy. Apart from that, it could be lactose intolerance would be inflammatory bowel disease, which is Crohn's disease, Whipple disease, some parasitic infection like giardiasis. All of this can cause chronic diarrhea because of malabsorption. Also, we should not forget about cystic fibrosis. So, what is the normal feature of malabsorption? Because of malabsorption, the food, especially the fatty food, it cannot be digested. So patient comes with like a chronic diarrhea, and the diarrhea has a specific characteristic. So the stool will be bulky, pale, very offensive, foul smelling, frothy, greasy stool. Because why it is greasy? Because fat is not getting digested. And it is also very difficult to flush. So that's the main finding: bulky, pale, frothy, hard to flush, greasy stool. Because of malabsorption and lack of digestion, patient can have weight loss. They can get bloated abdomen. They can also have multiple vitamin deficiencies, especially the vitamin which require fat to get digested or absorbed, which is vitamin A, D, E, K. Okay, and these patients also can develop anemia. Most importantly, folic acid deficiency, B12 deficiency, or iron deficiency anemia. So coming to celiac disease, which is gluten-sensitive enteropathy, very common in Australia. So what happens in this case is that patient who takes gluten, especially for celiac disease patient, the gluten can cause flattening of the villus. So you know the small villi which is on the intestine, which causes the absorption of the food and nutrients. Those villi can get flattened because of an autoimmune reaction. So basically, celiac disease is an autoimmune condition in which the antibody attacks this villi, makes it flat so that it cannot absorb the nutrients. And it mainly happens after taking something which contains gluten. So which contains gluten? Anything which has oats, rye, or wheat, barley. Okay, so oats, rye, barley, wheat. These are the main thing which has gluten in it. So anything patient takes like bread, oats, so all of these things can have gluten. Okay, so after taking those carbs, if a patient develops diarrhea, then you should think of celiac. So there is a first degree relative chance. It is an autoimmune disorder, but it has genetic factor. So we say that 1 in 10 chance to have a celiac disease if a first degree relative is affected. So clinical feature, because of malabsorption, patient will be very tired and fatigued, weight loss, diarrhea, iron deficiency, folic acid deficiency, abdominal bloating. Patient can get abdominal bloating with flatulence, ulceration. They can get very pale and thin, no subcutaneous fat. So how to diagnose gluten sensitive enteropathy or celiac disease? So this is a very important topic. So if you suspect a patient to have celiac, you start with a celiac antibody test. So the antibody test nowadays we do is called deamidated gliadin peptide. This is the highly sensitive and specific antibody. So this DGP is the main test. Apart from that, you can also choose IgA transglutaminase antibody. Okay. If any of these tests come back positive, then the confirmatory test is duodenal biopsy, and in duodenal biopsy you can get villus atrophy, and that is the confirmatory test. So because it is an autoimmune condition, patient with this condition can have other autoimmune problems like pernicious anemia, type 1 diabetes. They have increased risk of lymphoma, okay, iron deficiency. So all of this can be associated with celiac. So what is the management? Once you diagnose the patient, management is simple. Don't take anything which contains gluten. So gluten-free diet is the treatment. Okay. And Dr. Bilal, which investigation to repeat? Oh yes, pseudomembranous colitis. So you do, your initial test is C. difficile toxin stool test. So you do a stool PCR. That's the first test. And confirmatory is sigmoidoscopy with tissue culture. Whipple disease is not needed for your ischemic colitis. Very important. So ischemic colitis is a condition which is associated in elderly patients. And in this condition, there is atheromatous occlusion of the mesenteric vessels. So this can be the start of acute mesenteric ischemia. Okay, remember the acute mesenteric ischemia in our last class? So what happens in there, that the mesenteric vessels, which supplies the gut or intestine, it can start to get atheromatous occlusion. And when it starts to get narrowed, there is lack of blood flow to the gut, and patient presents with a periumbilical pain and diarrhea, usually 15 to 30 minutes after eating. Okay, so abdominal pain, especially periumbilical, with bloody diarrhea, 30 minutes after eating, that is something which you can think of ischemic colitis. And the only way to confirm the diagnosis is to do a CT angiogram of the mesenteric vessels. Acute gastroenteritis in children, which is not needed. You can go through that in your own time. The most common cause of diarrhea in children is rotavirus and adenovirus. If a child is having acute diarrhea, the main thing that you assess is how is their hydration status. So mild, moderate, or severe. If a child is having mild dehydration, all you need to do is to ask the parent for oral rehydration. So allow them to give small fluids often, continue breastfeeding, and start solid after 24 hours. If it is moderate dehydration, oral rehydration can be done either by NG tube. If NG tube is not possible, then IV fluid, like an IV fluid. So for moderate dehydration, the child needs to be sent to the hospital. First, they can try just a NG feeding. If NG feeding is not possible, then IV fluid. And definitely for severe dehydration, urgent IV fluid will be needed. So you can go through this like management of diarrhea in children, not super important. Lactose intolerance in children. Honest sugar is lactose, right? So what happens in lactose intolerance children, that whenever you give them milk, especially cow's milk, the child can start to have this kind of a watery, frothy, smell like vinegar kind of a diarrhea. So watery, frothy, vinegar like a smell, that's the time you would think of lactose intolerance. Okay, because it contains sugar, patient can also have a bit of a like excoriation of their buttock, because it can cause a bit of itchiness. Diagnosis: to diagnose lactose intolerance, you can do lactose breath hydration test or hydrogen test. So that is how we diagnose them. Lactose breath hydrogen test. So treatment: because the child cannot tolerate lactose in the milk, so you'll need to give them lactose-free milk. So most of the time you can give, there are lots of lactose-free milk available in the market, so there is enough, or sometimes you can give them soy milk. Okay, but lactose-free milk will be the choice. There is a condition called toddler's diarrhea. This is also in children. So it is a condition which happens in toddlers, which means children between 1 to 3 years of age. So in these children, there is nothing wrong. They eat well, they grow well, so everything is good, but they get this kind of a loose, bulky, non-offensive stool, and they will have this kind of undigested food materials in their stool. This is associated with children who has a lot of fruit juice. That's why it is also called fruit juice diarrhea. Okay, so it's a toddler between 1 to 3 years having this non-smelly, bulky stool, and also there is undigested food particles in it, but everything else is normal. That's toddler's diarrhea. So you can go through this traveler's diarrhea by yourself. Just remember the name of the antibiotic. Okay, so sometimes they can say that patient, you have done the stool microscopy culture and it came back positive for Shigella. What is the treatment of choice? Cotrimoxazole. So what is the treatment for giardiasis or giardiasis? Metronidazole or tinidazole. So just remember the name of the antibiotic for this. Okay, very important topic is IBD or inflammatory bowel disease. So as the name implies, so this is inflammation of the bowel. There are two subtypes of IBD. One is ulcerative colitis and another is Crohn's disease. So it's usually a young person who presents with a bloody diarrhea and mucus, abdominal pain, urgency to visit toilet, and with that they have malaise, weight loss. That's the time you would think of IBD. So basically it's a young adult patient coming to you with a bloody diarrhea with a bit of abdominal discomfort. That's the time you think of IBD. Okay. So for IBD, the main investigation or the only way to confirm it is by colonoscopy. But initially, you can even do a fecal calprotectin. If fecal calprotectin is normal, there is no inflammation. If it is abnormal, then patient will need a colonoscopy. So initial test, you can consider doing a fecal calprotectin. If calprotectin is high, then definitely colonoscopy. So ulcerative colitis. Ulcerative colitis mainly involves the large intestine and it causes a bit of a ulceration in the large intestine. Okay, so mainly young patient, family history can be positive, recurrent attack of loose stool. So the main presentation is bloody diarrhea. So blood and mucus in stool. Abdominal pain is not very very severe, but patient can have fever, malaise, weight loss. It only affects the colon. Okay, there is an increased risk of colorectal cancer with patient who develops ulcerative colitis. So main symptom is bloody diarrhea. How to diagnose? First fecal calprotectin and then colonoscopy. Crohn's disease. Crohn's disease, the main presentation could be colicky abdominal pain. So they get colicky abdominal pain. Along with that, they also get a bloody diarrhea. But Crohn's disease, it can affect the whole GIT. Okay. So from mouth to anus, it can affect. And also constitutional symptoms like fever, weight loss, malaise, these are very common in here. They also develop perianal disorders like patient with Crohn's, they have high risk of developing anal fissure, anal fistula, ischiorectal abscess. Okay. How to diagnose? For Crohn's disease, the usual diagnosis depends on sigmoidoscopy or colonoscopy. Prognosis is less favorable than ulcerative colitis. So how we treat inflammatory bowel disease. So if it is acute treatment, for acute treatment, usually you need to put them on a steroid. So a steroid is mainly for flare-up. And there are lots of steroid, like you can give them orally, parenteral, topical. So mainly a steroid is the treatment of choice for acute flare-up. But they also need to be on some maintenance treatment, which will be mainly sulfasalazine. So 5-amino salicylic acid derivative, which is sulfasalazine, olsalazine, or mesalazine. So that's usually the maintenance treatment. For severe conditions, sometimes even immunomodifying drugs such as azathioprine, methotrexate, or even TNF inhibitors, they might be needed. So that is IBD. And also for patient who has Crohn's disease, they have possibility of a extra-intestinal symptom. So extra-intestinal symptoms are common in Crohn's disease patient. And extra-intestinals are arthralgia, low back pain. They can get like a uveitis, liver disease, skin lesion like erythema nodosum. So these are common in Crohn's disease patient. Okay, arthralgia, uveitis, liver skin conditions. The thing is that it is very difficult to differentiate Crohn's and ulcerative colitis based on its symptoms. So most of the time you will start with fecal calprotectin. Unless in the stem they give all the symptoms of Crohn's disease with extra abdominal features and everything, then doing a fecal calprotectin is usually not needed, because fecal calprotectin is usually what we do in ulcerative colitis, not in Crohn's. Next, IBS or irritable bowel syndrome. Also very common. It's important for exam. It is common in younger women, and most of the time it has some kind of psychological stress underlying. So irritable bowel syndrome, the main presentation is cramping abdominal pain, pain relieved by passing stool or passing the bowel. Patient can have constipation, predominant IBS. They can have diarrhea predominant IBS, or they can have alternating constipation with diarrhea. Okay, so cramping abdominal pain, pain relieved after opening the bowel, and then they can have diarrhea predominant. If it is diarrhea predominant, diarrhea will be worse in the morning, and they will feel like an urgent need to go to the toilet. If it is constipation predominant, they get kind of a hard pellet or ribbon-like stool. So how to diagnose? Basically, if you have got a patient who is young female patient, not only female, can happen in male also, young patient having, let's say, having abdominal discomfort or pain, which is relieved by opening the bowel, and also they have diarrhea or constipation or a mixture of both, then you can think of IBS. And definitely an IBS patient will never ever have a bloody diarrhea, and they also should not have any red flags like weight loss, loss of appetite. Those are not common. The patient needs to be educated that this usually has some kind of stress underlying, and sometimes also some of the diet can cause it. So initial treatment is dietary modification. We call low FODMAPs diet is mainly the treatment of choice. So it's basically low FODMAP diet has good prognostic value. Now, what is low FODMAP? I'm not going to discuss, which you also doesn't need to know. A dietitian will be the one who will discuss about it. If low FODMAP diet does not help, then normally after 12 months of trying the dietary modification, still not helping, and patient is under a lot of stress, you can try some antidepressant like SSRI. Okay. Next, diverticular disorder. Remember in our last class we discussed diverticulitis. So that is like initially patient developed diverticulosis or diverticular disorder. So this is also common. This is common in patients who are a bit elderly, so middle-aged to elderly above 40. Patient in this condition have a long-term constipation, and they sometimes can get a bit of abdominal pain in the left iliac fossa, and sometimes they can get a profuse parectal bleeding. So that is diverticula or diverticulosis. Sometimes this diverticulosis patient can have infection in the diverticula causing diverticulitis. So then the patient can develop fever, nausea, vomiting. Again, so patient with diverticular disorder, they are middle-aged or elderly patient who has prolonged constipation. They also have like left iliac fossa pain. Sometimes you might be able to feel a left iliac fossa mass and also profuse parectal bleeding sometimes. But they will not have any systemic sign. But the same patient, if they have nausea, vomiting, fever, the term will be diverticulitis. So how to investigate this patient? If it is just diverticulosis, the only way to confirm is colonoscopy or sigmoidoscopy. But you will not do colonoscopy if there is a chance that this patient has diverticulitis. Because during infection, the colon is very swollen and edematous. You can easily perforate the colon. That's why during diverticulitis, colonoscopy is contraindicated. But if it is just diverticulosis, no systemic feature, then you can do a colonoscopy. The treatment is basically high fiber diet and avoid constipation. Any medication for diarrhea or constipation in IBS? So for diarrhea, usually we try some dietary modification. Sometimes if it is really bad, you can try some loperamide, but it is not the first line, second line, or even third line treatment. Okay, so for diarrhea, nothing much, but for constipation, they can try some laxatives, like increased fiber. They can use the psyllium or ispagula husk, some laxatives also that can be used. But for diarrhea, usually nothing. Does patient with ulcerative colitis need screening for colon cancer? It's not just for colon cancer. Patient with ulcerative colitis or IBD, they usually have like annual colonoscopy anyway. But this is not a part of screening. So it depends on the IBD specialist how often they want to do it. All right, everyone. So that's pretty much everything that we are going to discuss today. As you can see, there is a lot to know from GIT, and it is a bit difficult than other topics that we have done so far. The only thing we could not discuss in our class was jaundice, so which normally we can't because there's a lot to discuss. The jaundice chapter we will discuss as part of left out topics. Usually we do any of the left out topics which we can't finish in our given class time. We discuss at the end of the course. Okay, so jaundice usually we do it at our last few classes. So that's how we are going to cover it. Anorectal disorders, usually we cover it in our surgery class. Okay. Other than that, everything is finished. Please make sure to finish these topics as soon as possible because you might forget these things if you keep it on hold. Any question, guys? Are you guys enjoying our session so far? This is almost 2 months of the course. You are learning everything. You are doing some question solvations with your study partners. Yeah, very good. I can't remember, Dr. Isra, that which class we have done the jaundice. Most likely it was, we call these classes as end of course, or end of course classes. So find out if there is something in your previous video lecture as end of course class. All right, Dr. Tahrim, just join the course. It must be overwhelming. What I would suggest for anyone who is very new to the course is first listen to our orientation video lecture. We discussed everything about MCQ, how you should prepare and all. So first go through that video and then start gradually. The missed classes, you have the recordings in the portal. Whenever you get some time, try to cover those as well. So the one that you guys have shared, salbutamol ipratropium. So it's a very good question. Do you guys remember the asthma attack that we have discussed from RCH? Open up the asthma attack. You should be able to find out the answer. Let me show you. So go to the acute asthma attack from RCH. So let's see the questions that you have shared. So it is an acute asthma attack in an 8-year-old, right? Can't be sure that what kind of asthma, is it mild, moderate, or severe asthma attack, but it's fine. So we say that if it is a moderate asthma, you give the salbutamol every 20 minutes for 3 doses. And then you look at that if the patient is getting like a well response or not. So normally above 6-year-old, 12 puff every 20 minutes for 3 doses. Give oral steroid as well. Okay. And then reassess at 30 minutes after the third salbutamol dose. If it is good response, if it is yes, then reassess at 1 and 2 hours after third dose. See if it is good response or not. If it is good response, that is fine. If it is not good response, we say that along with the salbutamol, you can also give them ipratropium. Okay, so that's usually for moderate. Let's come to the severe asthma. For severe asthma attack, 12 puff of salbutamol and then 8 puff of ipratropium. And after that, we give them a steroid. So the main thing is that from the question, you need to find out, is it moderate or severe asthma attack? Ideally, we say that this is how we differentiate. Moderate means child is active and alert, increased respiratory rate, but severe means the child is pale, agitated, and there is marked increasing work of breathing. Okay, so if the child is confused, drowsy, cyanosed, pale, agitated, these are very severe. If it is a severe asthma attack, then yes, you are going to start the child with both salbutamol and ipratropium at the same time. If it is not, then you just start with salbutamol, and along with that, you can use a steroid. So that's what they actually say in here. So you'll need to find it out from the question what type of asthma attack it is. It is not always that nebulized salbutamol means that it is life-threatening. We can give either inhaler or nebulized as at any form of asthma attack. Doesn't matter. Okay. So this is what you should follow. So if after salbutamol there is not good response, especially we say after third dose of salbutamol there is no response, okay, then we normally go for, you can see that in here they say 12 puff of salbutamol and give oral steroid. Let's calm down. Okay, nothing much. So in case of a moderate asthma, salbutamol and steroid will be your initial addition of medication. If it is a severe or life-threatening, then salbutamol plus ipratropium at the same time and then steroid. Okay. So these kind of questions, the questions that you guys have shared, that's not a complete question. They usually write very clearly that what kind of asthma it is. Like they usually write acute severe asthma attack. If it is severe asthma attack, the answer will be ipratropium. From this question, we can't say anything. There is nothing written in here, right? So this is not a complete question, but as I say that in exam, they will always give you a complete scenario. So you will definitely know what kind of asthma attack it is. So get your theory knowledge really good so that you know what to choose based on the full stamp in the exam. Okay. All right, everyone. So we'll finish it here tonight. Thank you, everyone. Have a good